Hello class, this is Professor Hale. I'll be covering fluid balance and imbalances in this video. This is part 1 of chapter 29. So here are your learning outcomes. They are all derived in your book in chapter 29. So I suggest you read them. This is just for this portion of the video. By the end of this video and by the end of this content, you should be able to define various terms associated with fluids, identify body fluid compartments, describe the functions and movements of body fluids, and explain how fluids are regulated in the body, describe the fluid volume imbalances, such as the fluid volume deficit, which is hypovolemia, and fluid volume excess, which is hypervolemia, and also identify nursing actions to take for the patients with fluid imbalances. All right, let's begin. So body fluids. So what is it? Our body consists of majority of it is water. So to give you an idea, our blood is really pretty much composed of 80% to 83% of water. So that's how much, that's the importance of that. So water, it kind of comprises of like at least approximately 50 to 70% of water, and this is in a healthy body weight. And in a healthy older adult, it decreases as we age to 50 to 55% of water. And infants, their body weight is usually higher, which is 65 to 80% of water. So this is something that you kind of, keep in mind. So remember that the reason why, and also for an example, it affects the body water, varies. It depends on age and the gender. So just for example, a male has a higher percentage of body weight because they have more muscle. So think about muscle. It actually retains more water. And some people may think of a person who's overweight or obese. They may have more water, but no. Just kind of think of like the fat, when there's fat in our body, oil and water, it repels. So we will not have that, it would not retain that much water. So the more muscle you have, the more, the percentage of body weight of water that you will have. So that's a good note to have. The more muscle, the more body weight you have. So there's a distribution of the body fluids. They have two compartments within our body. We have the intracellular fluid, and this is within the cell. It is pretty much comprises of 2/3 of our body fluid. So that's a lot. And then we have the extracellular fluid, which has, two compartments or three compartments, and the extracellular fluid is a little smaller amount, but it covers 1/3 of the body water. And this means the extracellular fluid is outside of the cell membrane. Here you can see on the right, there's the pie chart there, and it also has a little, about 3 parts of it with the extracellular fluid. We have the intravascular and interstitial and transcellular. These are the compartments in the extracellular fluid, which is important. Our interstitial, which is between the cells and it's outside our blood vessels. The intravascular is pretty much our blood, our plasma. It's within the arteries, veins, and capillaries. And then we have the transcellular, which is a smaller amount of fluids, and the extracellular fluids, which covers the cerebral spinal fluid, pleural, peritoneal, digestive fluid, juices, and the synovial fluid joints. So this is a good overview of how our body fluids move throughout our body, and this is pretty much through osmosis. We have the terms of diffusion and filtration. This is something that you can read in your chapter 29. It gives a really good detailed overview of this, so I'm not going to really go too in depth into this, into the osmosis. So what are the functions of our body fluid? So they pretty much, they regulate, they maintain our temperature, they transport nutrients and gases throughout the body, such as our electrolytes, minerals, vitamins, and waste products. They protect our brain and spinal cord, and they lubricate our joints and our digestive tract. So the regulation of body fluids, it's pretty much to kind of like giving an overview, it's pretty much the most important factor determining water intake, and that is thirst. The hypothalamus is in the brain. It receives information from the osmoreceptors, which detect when there is an elevated concentration of solutes in the blood. Increased concentration of the plasma, which is osmolality, it's what results in a low fluid levels in the blood. So this stimulates thirst. So, however, it is too much fluid, or it can be there could be a problem with the osmoreceptors. The hypothalamus in the brain, it does not cause you to be thirsty. So the water intake. So as you will learn in chapter 23, the average adult needs to consume somewhere between 1.5 to 2 liters of water per day, each day. So some individuals may need more water intake, such as pregnant or nursing women. So those individuals who work or exert in extremely hot environments and athletes, so they will need more water consumption as well because they'll lose it. So continue on with how the body fluids are regulated by. So normal fluid losses, it's pretty much the most obvious way in which the body loses fluid is through elimination of urine and feces. So fluid is lost through urine, is controlled by the antidiuretic hormone, which is a vasopressin, and aldosterone. So, and most insensible fluid loss. So insensible fluid loss is that which cannot be directly measured, such as fluid that's lost during respiration and perspiration. And then we have the hormone regulation. So this is like several hormones. They help maintain fluid levels in the body, and they produce an appropriate volume of urine output. Antidiuretic hormone, which is the ADH, and aldosterone, they both work on the kidneys to decrease urine production and increase body fluid level. So the atrial natriuretic factor, which is the ANF, that causes kidneys to excrete more urine to decrease the body fluid level. Um, and that's pretty much it for that. So kind of a little bit more on the hormones. So the antidiuretic hormone, it's when the blood becomes more concentrated with less water than usual. So this is when the hypothalamus in the brain stimulates the release of the antidiuretic hormone. So this hormone acts on the kidneys, and it's causing them to increase water reabsorption, which makes the urine more concentrated. So then we have the aldosterone. This is when more water is reabsorbed, the blood volume increases and pressure goes up. And it's because it regulates the fluid and electrolytes by telling the kidneys to reabsorb more sodium and excrete more potassium. So this causes more water to be reabsorbed by the kidneys and circulate in the blood. So the principle of water flows, sodium is at work here. So just remember that where water, where the sodium goes, water flows. So they kind of work hand in hand. And then you have the atrial natriuretic factor, which is the ANF. This is when there is excessive blood volume. It causes the blood pressure to go up. The hormone atrial natriuretic factor is when produced. It causes the production of the renin to be suppressed, which interferes with the production of aldosterone. Now the kidneys will excrete more sodium and therefore more water. So this increases the urinary output and it lowers the blood pressure. So moving on to fluid volume deficit, we have which could be hypovolemia, and it results when the patient loses both fluid and electrolytes contained in that fluid. The most common cause for this loss is a large amount of blood, and this is through hemorrhage. So when the patient loses only fluids, the remaining electrolytes become more concentrated. So this is called dehydration. Hemorrhage and dehydration, they require different treatments, so be mindful of that. Fluid volume deficit is caused by prolonged insufficient fluid intake or loss of fluid. Patients with fluid loss may not always experience thirst, especially older adults and patients with brain injuries. So kind of little safety note here, young children, they should be offered fluids often because they can develop fluid volume deficit if they are without fluids for a prolonged time. The causes for fluid volume deficit, we have vomiting and diarrhea, fever, extreme heat exhaustion, extreme exhaustion from exercise, severe burns, hemorrhage, diuretics, which are furosemide or hydrochlorothiazide. Those are the things that can actually cause fluid loss. And diabetes insipidus, which we'll learn more about when you have your endocrine content. Signs and symptoms of fluid volume deficit, you can see thirst, rapid weak pulse, hypertension, which is low blood pressure. You can see like dry skin and dry oral mucosa membranes, poor skin turgor. So turgor is like pretty much, if you kind of like pinch the skin and it's in people, and if it stays like that, it's called tenting. So that indicates if there's any if there's no fluid. So they don't have that elasticity as a person that has more volume and fluid. The skin can be cool and moist. They have a decreased urine output, becomes more concentrated, increased temperature. With infants, they will have a sunken or depressed fontanelles. And then for severe signs and symptoms, it will be a decreased level of consciousness and confusion. So that's something that you really want to keep aware of when somebody has a fluid volume deficit. And also you want to make sure, measure the fluids as well, monitor that their output. And that is pretty much for that. So here's a good picture overview, kind of the difference between hypovolemic shock. We'll go over that more when we review the shocks and stuff like that further in this content, in this program. But this kind of gives you an idea of the two different treatments of hypovolemic shock and dehydration. You can see the signs and symptoms, which, late stage is pretty much altered mental status. That's not good. So they'll feel restless. They will be in some kind of disorientation may be present. They will have hypovolemic shock. They'll have a rapid heart rate, which is called tachycardia. Dyspnea, when this is due to the blood loss and the lack of blood cells which carry the oxygen. So that's something, sometimes they may need O2. They'll need oxygen to replace. They'll have cool, clammy skin. This is due to the blood loss. Or they may have obvious bleeding. So the thing is, you want to kind of control the treatment. You want to control kind of determine the underlying cause and treat that. They'll have a decreased urine output due to low volume. Patients with output should at least have 30 mLs per hour or 1 ml per kilogram per hour. Hypotension, they may have a drop in blood pressure due to decreased blood volume. IV, so the treatment for that is IV fluids, but if it does, sometimes you can only, you kind of pretty much fill in a tank at this point. So if that doesn't work and, the patient's not responding, then they'll have to resort to blood transfusion. And fluid replacement therapy for the patient. This is pretty much the gist of the hypovolemic shock. And then you have the dehydration. So when there's no water, there's no salt or both. So this is due to inadequate fluid intake. They can have vomiting, diarrhea, and loss of fluid and electrolytes. So what are you going to monitor? You're going to monitor the electrolytes. And you want to watch for changes for skin turgor. So here are your nursing actions for fluid volume deficit. This is something that's really good to know. You want to provide oral or IV rehydration therapy. Monitor weights. So if you're going to do daily weights, make sure you do it first thing in the morning and try to do it at the same time every day to get a really accurate. And standing scale is optimal. That's pretty much the best way to get it more accurate. Some acute settings, you'll have a built-in bed scale, which are not always optimal for measuring an accurate weight. Monitor I&Os. As I said, urine output should be 30 mLs per hour. Monitor vital signs or orthostatic to determine if they have orthostatic blood pressures. And then you want to monitor for fall risks. If they are fall risk, you want to implement fall risk measures and safety measures as per facilities policy. You want to assess their gait, monitor the changes in mentation. Some people can get confused when they're, especially the elderly. Um, Assess moral, the oral, not moral. That is a typo. Apologize for that. Assess oral mucosa, which is dry. They'll have like dry, cracked lips. Administer the antiemetic medications as ordered for nausea and vomiting, and anti-diarrheal medications for loose stools. So now we're going to move on to fluid volume excess, which is hypervolemia. This is because there's excess fluid in the extracellular fluids, which is water and sodium. So causes for this could be congestive heart failure. We'll learn more about that when you go into the cardiac content. Early renal failure can cause fluid volume excess, IV therapy, excessive sodium ingestion, corticosteroids. They're all examples of causes of hypervolemia. The symptoms that you're going to see with hypervolemia is tachypnea, dyspnea and crackles. So tachypnea is you're going to see that increased respirations. You're going to see fast respirations. Dyspnea, you're going to see like they're going to have shortness of breath, especially with exertion. And then you're going to auscultate lung sounds. So you'll hear like a crackles or rails. Those are the things that you'll hear, and those are indicative of fluid in the lungs and fluid build up there. So those are the things, especially if somebody is with IV hydration or doing IV fluids, you always want to assess the lung sounds. Those are the one things that you always want to assess throughout your shift to make sure that they're not having fluid overload. Especially, you have to be very careful with people who have kidney issues, kidney diseases, or heart failure. You'll see a rapid bounding or abounding pulses. So when you assess your pulses on the pedal pulses or your radial pulses, you'll feel them be bounding. So that means that could be indicative of fluid volume excess. They will have hypertension. Unless it's heart failure, they'll have a distended neck and hand veins. So their veins will be bulging out. Unless they're like weightlifters, professional weightlifters, and that's a different story. But average everyday person who's not a weightlifter, professional weightlifter, you'll see bulging veins, especially in the neck area. That's called a jugular vein distension of the vein, or jugular vein distension, which is called JVD. You'll hear that throughout this content program. So that will be on the neck, and you can see it kind of like bulging out. And then they'll have acute weight gain, and they'll have edema or pulmonary edema. So that's when you'll probably hear the crackles. So and then they'll have like pitting edema. So pitting edema, those are the things that you want to assess. So it's kind of like if you want to look at like if you the pedal pulse of the pedal pitting edema. So you want to like, it kind of like is almost like pressing down on Play-Doh. There's an indentation, so it determines if it rebounds back to baseline. You'll see like different scales of pitting edema, and it goes from 0 millimeters to 4 millimeters. 4 plus pitting edema is severe pitting edema, and 1 plus pitting edema is mild pitting edema. So this is when you have a depression that disappears rapidly when you push down on the skin. 2 plus pitting edema is moderate pitting edema, and this is when you'll have like a 4 millimeters depression that disappears in 10 to 5 seconds. Then you'll have 3 plus pitting edema, which is moderately severe pitting edema, which will depression that may last more than 1 minute. So those are the kind of things that you can determine what kind of pitting edema it is. We'll get more into that when we get into the cardiac. This is just an FYI, but definitely just know that there will be edema with hypervolemia. These are your nursing actions for fluid volume excess. They're going to need to be on a strict INO as ordered. Fluid restrictions. Sometimes you'll see like a fluid restriction of 1,200 mLs. It just depends on what the physician orders. 1,600 mLs per day. So you're going to have to rationalize each shift of what they can have. that will equal up to 1,600. So each shift you could probably have like 250 with med, 240 with meds, or it's going to be it determines like 7 to 7, 7A to 7P. If you have a 12-hour shift, they'll probably have 800 mLs, and you want to kind of break it up throughout the day. Like they can have 240 with lunch or breakfast. Those are examples of that. Administration of diuretics as per physician's orders. Monitor electrolytes. Those are the huge, with any volume deficit, monitor electrolytes. Those are the huge thing. Low sodium diet, you want to place them on because you know why? Because wherever sodium goes, water flows. Water just kind of follows sodium. It's pretty much sodium stalker. Monitor vital signs every 4 hours. Auscultate lung sounds and heart sounds every 4 hours. And you want to assess for dependent edema, which is in the lower extremities. And that's what I was talking about with the pitting edema. There's an example of that.